going to perform a basic cardiovascular examination today. This is at the Med 1 skilled clinician level. Todd has kindly agreed to be our model for this. Thank you, Todd. I'm going to start with inspection, and I'm actually looking at Todd's work of breathing now. Patients with heart failure tend to accumulate fluid in the lungs and can have quite significant problems with respiratory distress. I can see that Todd is resting comfortably in a semi-recumbent position, and he is not having any problems with his work of breathing. As part of the inspection, I'm going to look at Todd's jugular venous pulse wave. For this, I'm going to apply some tangential lighting. I have Todd at approximately 30 degrees inclination on the bed, and I'm going to ask him to turn his head slightly to the left and just down a fraction. I'm looking for pulsations in the neck around the area of the sternocleidomastoid muscle. I'm going to get my light into a comfortable position, and I'm looking along this area for any evidence of pulsation. In normal people in the resting state who don't have raised or lowered jugular venous pulsation, the best place to look at 30 degrees is actually right at the base of the neck. And I think if you look closely here, you can see pulsations at the base of Todd's neck. And we'll look at those for a moment. If you look closely, you'll actually see this is a double waveform. And it's actually going at twice the rate of the pulse because it has two components. So we'll look carefully at that. Features of the jugular venous pulse wave that make you know it's jugular venous pulse is that it can be occluded, whereas the carotid artery cannot be occluded with light pressure. I'm going to put some light pressure at the base of the neck. And the pulsation there has gone away. You'll notice at the same time that the external jugular vein actually fills with blood, and when I take the pressure away, the external jugular vein will empty, and the pulsations at the base of the neck will reappear. And the pulsations are back. I'm going to ask Todd to take a deep breath in, and the pulsation level will drop. And breathe away. And the other thing I'm going to do is I'm going to apply light pressure with a clenched fist over the area of the liver. Todd, let me know if this is uncomfortable. What I'm watching here is for a slight rise in the jugular venous pulse wave height. I think the pulse becomes much more obvious, and now the height seems to be up to about here. That only lasts for a few beats in someone who's normal, and then that goes away. When you've looked and seen the jugular venous pulse wave, and when you've ascertained where you think the peak of the wave is, then you can measure the height. The height is measured above the sternal angle. So I find the suprasternal notch, come down the sternum to find the sternal angle. So I'm going to be measuring the height above the sternal angle. To help me with that, I'm going to put this tongue depressor at the level of the top of the external jugular vein, and then use a ruler to measure the height. And you can see that this is barely half a centimeter above the sternal angle, perhaps 1 centimeter above the sternal angle. In order to estimate the central venous pressure, you add 5 centimeters to that, and that would give us 6 to 6.5. And in this case, that's a normal jugular venous pressure, and this is a normal jugular venous pulse wave. So I'm going to turn the light out now and move the light out of the way. I'm going to palpate the radial pulse. As you saw in the vital signs video, this is usually done with 2 or 3 fingers. And I'm estimating the rate. And I'm checking for regularity of the radial pulse. And I'll check both radial pulses. As I work my way up the arm, I'll check both brachial pulses. And I'm going to check the carotid pulses. Now we do this one at a time. And those pulses are all normal. I'm going to move on to the precordial examination now. I'm going to start by inspecting the precordium. I'm looking for any scars in the precordium to suggest previous surgeries. I'm looking for any obvious pulsations in the precordium, and this all looks normal. I'm going to palpate over this area. I'm going to find some anatomical landmarks. Once again, I'm going to find the suprasternal notch, the sternal angle, and I know that the second rib joins the sternum at the sternal angle, so I'm able to count rib spaces. So now I'm in the second intercostal space to the right of the sternum, second intercostal space to the left of the sternum. I'm going to come down to the lower sternal border and go on the left side. Now I'm at the left lower sternal border. And then I'm going to count rib spaces, 3, 4, 5. Now I'm in the fifth intercostal space, and I'm going to move out to the mid-axillary line. These are important areas for palpation, so it's important to identify them first and then palpate in those areas. You're palpating for obvious pulsations. You're palpating for thrills or abnormal vibrations under the skin. You can do that with either hand. Lastly, I'm going to palpate for the apex beat, which is normally in the fifth intercostal space in the midclavicular line. Todd's apex beat is slightly lateral to the midclavicular line, but well within the normal area. The apex beat shouldn't be palpable just as a single pulse, and it shouldn't occupy an area more than about the size of a quarter. And this is quite normal. In terms of percussion for the heart, there is not much to be gained by percussing the chest for examination of the heart, so I'll proceed on to auscultation. And I'm going to auscultate in the same areas. So I'm in the second right intercostal space. And sounds generated by the aortic valve, which sits just under the sternum, approximately here, radiate to the second right intercostal space. I'm going to listen in the second left intercostal space. And sounds generated by the pulmonic valve, which sits quite close to the aortic valve, then a little more laterally, radiate to the second left intercostal space. I'm going to listen at the lower left sternal border. And this is where sounds generated from the tricuspid valve tend to radiate. And finally, I'm going to listen in the fifth intercostal space of the midclavicular line. Which is where sounds generated from the mitral valve are best heard. In each of these areas, I'm trying to identify the first heart sound, or S1, the second heart sound, or S2. I'll just repeat the examination listening with the bell, which is better for picking up low-pitched sounds. And those heart sounds are all normal. I'm going to proceed to an examination of the peripheral vascular system. I've already felt the radial and brachial pulses and the carotid pulses. I'm going to listen over the carotid pulses for any evidence of bruit. Todd, you take a deep breath all the way in. Breathe all the way out. And stop. And breathe away. And do the same thing again. Breathe all the way in. Breathe all the way out. Stop. And breathe normally. And no bruits are audible in any of those vessels. Todd, I'm going to put you flat. hands by your sides. The aorta runs down the midline and bifurcates just around the level of the umbilicus into the internal iliac arteries. I'm going to listen over towards the aorta for bruits. And over the iliac arteries. In thin people, aortic pulsations may actually be quite obvious, and it may be possible to palpate the aorta. Usually do this with two hands to see if the palpation moves sideways rather than just up and down. This palpates as normal. The next major artery that can be palpated is the femoral artery. This is a sensitive area for examination, so please get the patient's permission to do this examination and explain what you're going to do. Todd, I'd like to feel the main artery in your groin. It'll involve me putting my hand underneath your shorts and pressing towards, in about this area here and here. Is that okay?
Yes.
Thank you. And the femoral arteries are normal to palpation. It's also possible to auscultate over the femoral arteries listening for bruits in the same way as you auscultate over the carotid arteries, but I'll not demonstrate that. I'm going to move down to do the rest of the peripheral arteries. The popliteal arteries sit in the popliteal fossa behind the knee and are best felt with two hands underneath the knee with the knee slightly bent. So I'm just going to lift your knee. And I'm going to cup both my hands underneath. I'll do the same on this side. And those are normal. I'm also looking at a normal hair distribution in the legs, which suggests a good arterial blood supply. I'm going to palpate the dorsalis pedis arteries, which usually run just on the lateral side of the extensor hallucis longus. I put my hands over a variable area here because this artery is not always found in the same anatomical position in everyone, and I can feel both these arteries quite easily. And then just swing my hands round to feel the posterior tibial arteries. And that concludes a normal basic cardiovascular examination. Thank you, Todd.
You're welcome.